So guys, if I'm audible and if I'm live, just give me a thumbs up. Let me know that I'm reaching out to you. So just give me a thumbs up if I'm audible to all of you. Okay, so it appears that I'm live. So today it's a introductory session where we will understand some basics regarding the ischemic heart disease, and we will build upon today's understanding in the subsequent modules where we will understand how to make the diagnosis of ischemic heart disease and how to manage them. Basically, there are a lot of things which are essential for us to understand from the very basic level. We need to understand the terminologies like stable angina, unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction, because going forward, the management for these scenarios is going to be different, right? So I'll start with one basic question. Good evening, everyone. When we talk about ischemic heart disease, we know that blood supply to some part of the myocardium is reduced because of occlusion of blood vessel. Now, what causes the occlusion of blood vessel? Atheromatous plaque, maybe a clot over it, right? Atheromatous plaque plus blood clot are responsible for occlusion of a blood vessel, resulting in reduced flow to the myocardium, and that causes ischemia. So let us begin with very basic question. When we talk about atheromatous plaques or atherosclerosis of blood vessels, we know that there is deposition of lipids, right, or the fat. But which layer of blood vessel this lipid or the fat gets deposited? Because when we talk about artery, it has three layers, right? It has tunica intima, tunica media, and tunica adventitia. So do you mean the deposition happens inside the lumen of the artery or inside any of these layers? Where is the deposition happening? Understanding this is crucial for us to understand the concept of ischemic heart disease. I'll tell you why. Right, Sutapa. The deposition of atheromatous plaque happens inside the tunica intima. So when you look at the blood vessel anatomy, you have an endothelium, right? The innermost layer, an endothelium. Then we have this layer called as tunica intima. Followed by that, you have a layer which you call as tunica media, which is primarily comprising of the smooth muscles of the blood vessel, and then you have tunica adventitia. So this intima, the innermost layer, intima, is where there is deposition of the atheromatous plaque. Okay. Now, can I say that on top of intima, when there is deposition, let me use this blue color to demonstrate atheromatous plaque. Okay, so if this is the atheromatous plaque that is getting deposited inside the intima, can I say that this is lined by the endothelium? So basically, the deposition happens between the endothelium and rest part of the intima. Okay, so as we go on depositing, the endothelium will start moving inwards, and we go on adding more and more atheromatous plaque, and this has resulted in narrowing of the vessel lumen, but it is still lined by the endothelium, and often on top of the endothelium there will be development of a fibromuscular cap. Fibromuscular cap. You may be thinking that why are we talking about all this? How is it related to clinical concept of ischemic heart disease? Okay, we will try to understand that itself. So to summarize, our artery has three layers: intima, media, adventitia. Atheromatous plaque deposition happens inside the intima. Okay, and when we look at the atheromatous plaque, it is occluding the lumen, and it is lined by endothelium and a fibromuscular cap. It is lined by endothelium and a fibromuscular cap. You can simply call it as fibrous cap or fibromuscular cap. Now it is this fibromuscular cap that is going to decide the outcome of this atheromatous plaque. If this is a strong fibromuscular cap, okay, if it does not rupture, then only problem that we are going to face is narrowing of its lumen. But if we do not have a strong fibromuscular cap, As atheromatous plaque goes on expanding, this will rupture, and as it ruptures, we will injure the endothelium. We will expose the atheromatous plaque content to the circulating blood. And when we do that, we have caused injury to the endothelium, right? And when endothelial injury happens, there is a possibility of development of a blood clot. Why that happens? Because in the subendothelial space, there is presence of what we call as von Willebrand factor. They get exposed, and von Willebrand factor, once it is exposed, it will attract platelets. And once we attract platelets, we will create a platelet mesh around it, right? Hello everyone. Hello everyone. So now the problem is, if the plaque ruptures, we activate platelet plug formation and eventually coagulation cascade, creating a fibrin mesh. As long as the fibromuscular cap is strong, it is not going to create major problems. Though we have compromised on the size of the blood vessel lumen, and thus the blood flow may be decreased, but it's not a major problem. But once I rupture this fibromuscular cap, in that case, I will create a platelet plug, on top of it a fibrin mesh, and this clot will eat up more lumen. It may even completely block the blood vessel. So when it is eating most part of the lumen or completely blocking the blood vessel, there will be severe compromise to the blood supply to the myocardium, right? Okay. So with this basic understanding, let us look at what all comes under the ischemic heart disease. Under the ischemic heart disease, we have chronic ischemic heart disease, where patient present as chronic stable angina. And then we have acute coronary syndromes, which includes unstable angina, non-ST elevation MI, and ST elevation MI, right? We will understand the pathophysiology of all of them. So first, let me start with what we call as a patient presenting with stable angina. Stable angina. Okay. So what happens is, in the tunica intima, let us say that this pink color layer is the tunica intima, and I start adding atheromatous plaque. Okay, so there is deposition of the atheroma, and as usual, as we know, on top of it there will be the endothelial layer, and there will be a fibromuscular cap. So now here the fibromuscular cap is strong, so we have a strong fibrous cap. As a result, what is happening? There is narrowing of the lumen, but no clot formation, right? So first thing that I understand in this patient is narrowing of blood vessel lumen, but there is no clot formation. Now, at this stage, when blood supply to the some part of the myocardium will be reduced. Okay. Now, this reduction may not be severe because I'm only compromising part of the lumen, right? It is not like 80%, 90% of the blood flow is cut off. So in such situation, what will happen? When I'm at rest, my myocardial oxygen demand is limited, and that much demand will be met by the lumen. But if I start doing physical exercise, I may reach a point where my myocardial oxygen demand is increasing, and that much demand may not be met by my this narrowed lumen. In such cases, because the demand is not being met by the narrow lumen, I will start experiencing anginal chest pain. So what is happening here? At rest, my myocardial oxygen demand is met. On exertion, myocardial oxygen demand is not met. So when will the pain appear? Only on exertion. If I take rest, again the myocardial oxygen demand will drop and the chest pain will disappear. That is a very typical story of stable angina. That is the typical story of stable angina. So in stable angina, there is no demand and supply mismatch at rest. So when I'm taking rest, my requirement of myocardium is met even if I have a narrow blood vessel lumen. But demand and supply mismatch becomes evident on exertion. Present on exertion. And because of that, the chest pain will obviously appear. Is it going to cause the death of the myocardium? No. If I take rest, the demand drops and the mismatch is again balanced and the chest pain disappears. That is why when we talk about stable angina, we always say chest pain appears only on exertion and it is promptly relieved by rest within 5 minutes, or it is promptly relieved by nitrates which cause vasodilatation within 5 minutes of taking sublingual nitrate. So this stable angina patient will present to hospital as a chronic case. They will tell that, sir, every time I walk 100 meters or every time I climb 2 or 3 flight of stairs, I experience chest pain. बैठ जाता हूँ 2-3 मिनट बाद सब ठीक हो जाता है और फिर चलने लगता हूँ, बट फिर 100 मीटर चलता हूँ तो फिर चेस्ट पेन होता है. दिस इज द यूजुअल स्टोरी. Chest pain brought about by exertion. Okay, so that is our stable angina, and we will count this as a chronic ischemic heart disease because there is no acute emergency in these patients. Myocardium is not dead. Okay, now think of another patient who unfortunately doesn't have this strong fibrous cap. He doesn't have the strong fibrous cap. In that case, what will happen? Some point of time when atheromatous plaque expands, the fibrous cap will rupture, and when it ruptures, obviously endothelium will be injured. So I'm talking about a second set of patients where the atheromatous plaque was lined by weak fibrous cap. Let me say it was lined by weak fibrous cap. So I had a fibrous cap, but that was weak, and here the fibrous cap and the endothelium have got ruptured. And once there is rupture, obviously there is exposure of 1 Willebrand factor, and that has got platelets to come and form a plug. So now here I have created a platelet rich plug. This is platelet plug. Platelet plug is formed here. And once the platelet plug is formed, there will be activation of coagulation cascade. And when we activate the coagulation, so suppose the fibrous plug is a thin sheet of connective tissue that forms over the atheromatous plaque. Its main job is to prevent the plaque rupture, which is not natural anatomical part. There is nothing called a fibrous cap in a regular blood vessel. Only when an atheromatous plaque is formed, it gets lined by the fibrous cap. Few muscle cells and some fibrous tissue. But that tissue is stopping the atheromatous plaque from rupturing. If it is strong enough, it doesn't allow the atheromatous plaque to rupture, then only problem you have is narrow lumen. And because of that narrow lumen, flow has come down. The decreased flow may not be a problem when you are at rest, but when you start doing exertion, you need more blood supply. That much blood supply may not be met by this small narrowed blood vessel, and then you start experiencing chest pain. That is our stable angina. But in the second scenario that I'm talking about, unfortunately, your fibrous cap could not contain the plaque, and it has resulted in rupture of the plaque. And once the plaque gets ruptured, there is also injury to the endothelium. Once we injure the endothelium, we will start platelet plug formation. Again, that takes me back to one important point. We have come across this thing called as Virchow's triad. Virchow's triad, which says 3 components are contributory towards formation of a clot, right? What are the components of Virchow's triad? One of them is stasis of blood. Whenever blood stagnates, doesn't flow, it has a tendency to clot. Second one is if you have inherently hypercoagulable state, hypercoagulability. And third, and the most important one, is the endothelial injury. Endothelial injury. So now we got that one point, right? We caused the endothelial injury here. And as we caused endothelial injury, 1 Willebrand factor was exposed that attracted the platelets. So we created a platelet plug. Now, once the platelet plug is formed, natural process of formation of clot is now we activate coagulation cascade, intrinsic, extrinsic pathways, and we form fibrinogen gets converted to fibrin. So we create a fibrin mesh. So now I have started creating a fibrin mesh around this clot. So let me say that I have created a fibrin mesh, very small amount of fibrin mesh. Majorly here, the lumen is occluded by the platelet plug, right? Lumen is mainly occluded by the platelet plug. So in this case, there is minimal fibrin load, maximal platelet plug. Now, when you look at this image, right, what we understand, The lumen is significantly now narrowed because we created a clot. At this point of time, the blood supply is significantly decreased. Example, if you want for the hypercoagulable state, there are some anticoagulant mechanisms inherently present in the body. One of them is protein C and protein S. So if you have deficiency of protein C, protein S, or there is something called as antithrombin. So if there is deficiency of antithrombin because of genetic mutations, we are at increased risk of developing clot. We call them as inherited thrombophilic states or hypercoagulable states. Another simple example is whatever that increases the viscosity of the blood becomes a hypercoagulable state. For example, if you're severely dehydrated, the viscosity of the blood increases, and the blood during severe dehydration is a hypercoagulable state. Okay. So now when we look at this lumen is very small, blood flow is significantly reduced. At this point of time, even my rest requirements of the myocardium, when I'm not doing any exercise, whatever myocardium needs, that much also may not be met. That much also may not be met. So then when will I experience the pain? At rest itself. So when I experience the pain at rest itself, what we call it as? Unstable angina, right? So at this stage, in the second scenario, the patient will have the demand and supply mismatch at rest itself. Mismatch at rest. And thus he will have angina at rest. And whenever someone has angina at rest, we call that condition as unstable angina. We call it as unstable angina. Now, isn't this a medical emergency? Because the flow, the need of your myocardium is not met even at rest. What if I allow the condition to progress? If I allow the condition to progress, see now the demand and supply mismatch is there at rest itself. If I allow the condition to progress, then I will have much more occlusion of the lumen, because as the time progresses, I will have deposition of more and more amount of platelets, because unfortunately the fibrous plug has failed to contain, it has ruptured, and the endothelium is injured, and I have created a big platelet plug, and I also have started adding more fibrin deposition. Lumen is significantly compromised. When that happens, the myocardium may start dying now. So Samantha, the fibrin load is a continuous process, right? As time progresses, I go on adding more fibrin. So when I started, I first created a platelet plug. That is a first step in the coagulation. Like, what is the first step? Formation of platelet plug. That also starts with platelet adhesion and then aggregation. Then we activate the coagulation cascade. So we start depositing fibrin. So this is a patient where we are at the early stage of fibrin deposition. And because of that, lumen is reduced, blood flow to the myocardium is reduced. Myocardium is experiencing demand and supply mismatch at rest itself. So I'm experiencing the pain. Myocardium is not dead yet. Now, as time progresses, little more fibrin is added and the blood flow to the myocardium is significantly reduced. At this time, myocardium starts dying. Okay. And now the basic question is where the myocardium will die first. Now here, this is a coronary artery. This yellow line is the pericardium and the green line is endocardium, and in between we have the myocardium. Okay. And as we know, the coronaries run on the epicardial surface and then penetrate from outside to inwards. Now this coronary artery has significant occlusion, right? Its lumen is pretty much closed. Maybe only 20% or 15% flow is possible because we have a large platelet plug and some amount of fibrin there. Now, because of this decreased supply, the myocardium will start dying. Which part will die first? Is it here or is it towards the endocardium? Whether I will have death of myocardium towards the endocardium or is it towards the pericardium? Obviously, even if there is lumen blocked, some blood coming, this will be able to meet the requirement of this part of the myocardium. But the requirement of the myocardium, which is further away from the point of entry of the coronaries, will not be met. So this is where the myocardium starts dying. If myocardium is dying here, Can I call it as infarction? Yes. Myocardium, when it is dead, we call it as infarction. Is it the full thickness of the myocardium that is infarcted? No. Partial thickness, right? Can I call this infarction as subendocardial infarction? Can I call it as subendocardial infarction? Yes. So we will call it as subendocardial infarction. So in the third scenario, demand supply mismatch, critical at rest, resulting in subendocardial infarction. Subendocardial infarction. Now, when you look at this, first thing we have to understand here is when I do an ECG of a patient with myocardial infarction, I will get ST elevation only if the whole thickness of the myocardium is infarcted. In such cases, we call it as transmural infarction. If whole thickness is not infarcted, I will not get ST elevation. I may have some other atypical changes, but not ST elevation. Infarction तो है, myocardium is dead. ECG में ST elevation नहीं दिख रहा है. So what should I call it as? I will call it as infarction is there. So it is MI. But ST elevation is not there because for ST elevation, the whole thickness of the myocardium should be dead. So what should I call this as? Because this does not show ST elevation, but still there is a myocardial infarction, I will call it as non-ST elevation MI or NSTEMI. Okay. Now, if I do not address the patient at this time, then what will happen? I will go on adding more. If I do not address the case at this time, then I will go on adding more fibrin thread. So there was a atheromatous plaque which has ruptured and we did not have a strong fibrin cap to protect it. So we ended up causing the rupture of the atheromatous plaque. This ruptured atheromatous plaque has started with the platelet plug formation, and then I have activated the fibrin plug formation, and there is extensive fibrin plug formation. Now the blood vessel is almost totally occluded, right? Near total occlusion. So here, in this case, there is demand supply mismatch, critical at rest itself, resulting in, see, there is a near total occlusion, right? So now at this stage, what will happen? The entire thickness of the myocardium will get infarcted. So when entire thickness of the myocardium gets infarcted, what will happen? I can see the ST elevation on the ECG. So when entire thickness gets affected, we call it as transmural infarction. And when we have transmural infarction, I will get STEMI, ST elevation MI. Okay. Now among all this basic questions, right? In a patient with stable angina, is there any platelet plug or the fibrin mesh present? No, right? There is no platelet plug. There is no fibrin mesh present in a patient with stable angina. Okay. In patients with unstable angina, myocardium is not dead, but the requirement of the rest is not met. That is why I'm experiencing pain at rest itself. Here I have a large platelet plug, but minimal fibrin load. And when it comes to the NSTEMI, in NSTEMI also there is slightly more fibrin load, but still in comparison to STEMI, I would call it as minimal fibrin load. On the other hand, in patients with the STEMI, where there is full thickness infarction, there is massive fibrin load. In unstable angina, the myocardium is suffering from ischemia. It is not dead yet. If you treat it, you can save it. If I do not address it, then it will go on to become NSTEMI. If I do not address it, it can transform into STEMI. So it is a sequence. Stable angina to unstable angina to NSTEMI to STEMI. It's a sequence. STEMI is the severe end of the spectrum. Stable angina is the mildest end of the spectrum. Okay, so in STEMI, there is massive fibrin load. Now, why am I so much stressing on fibrin load, fibrin load? Because in the next session, when we talk about the management of all these ischemic heart diseases, there comes a question. Should I do thrombolysis or not? And the thrombolytic agents, what do they do? they break the fibrin down. So in conditions where there is no fibrin or where there is no massive fibrin load, doing the thrombolysis does not help the patient. Only when we have massive fibrin load, I can break it down, I can open the blood vessel, right? So that is why thrombolysis becomes an important treatment for a patient with STEMI. There is no much role of thrombolysis in patients with NSTEMI and unstable angina. I hope we have understood the basics. Now we will put it on paper. How do we classify a case of ischemic heart disease? So ischemic heart disease is classified into acute and chronic. Into chronic and acute. And in chronic, all we have is patients with chronic stable angina. Chronic stable angina. These patients do not have plaque rupture. Their plaque is not ruptured because their fibrin cap, the fibrous cap or fibromuscular cap was strong enough. So it is containing the atheromatous plaque. So they have a stable plaque, narrow lumen, and because of the narrow lumen, during exertion, their myocardial oxygen demand is not met. At rest, it is met. So they don't have pain at rest. Only when they do some physical activity, they experience the pain. They take rest, the pain goes away, or they take nitrates, the pain goes away. On the other hand, in acute spectrum, we call it as acute coronary syndromes. These are all emergencies. And under this, what comes under this? The severe end, where there is transmural infarction, we have ST elevation MI. And when there is no ST elevation on the ECG, we call it as non-ST elevation acute coronary syndrome. Under that, we have unstable angina and non-ST elevation MI. Okay, so conceptually, what is it? In chronic stable angina, there is demand and supply mismatch only on exertion. Rest, no problem, no infarction. Okay. In STEMI, there is demand and supply mismatch critical enough to cause the infarction of the entire thickness of the myocardium, and that is why I have ST elevation. This is the severe end of the ischemic heart disease. Then in unstable angina, there is demand and supply mismatch at rest itself, but still myocardium is viable. It is not dead. It is on the way to death. So this is where I can intervene and save it from dying. But if I do not intervene, then some part of myocardium will die. If only the subendocardial myocardium dies, then I will call it as non-ST elevation MI. Okay. So this entire spectrum of acute coronary syndromes we will discuss in the next session. Where we will understand how to make the clinical diagnosis. Also, we will learn the ECG, how to recognize ST elevation MI, how to identify what is the possible blood vessel that could be blocked, which wall of the heart will be affected based on the ECG, and then we will talk about the management. Today we will take another 10 minutes talking about the management of chronic stable angina. I hope we have a fair idea about the spectrum of ischemic heart disease. On the chronic side, we have stable angina cases. On the acute side, STEMI, unstable angina, and NSTEMI. Okay. So when it comes to chronic stable angina, picture the pathophysiology. What is the pathophysiology? There is an atheromatous plaque which is caused the narrowing of the lumen. There is no plaque rupture. There is no platelet plug formation. There is no fibrin mesh formation. There is an atheromatous plaque which has caused the narrowing of the lumen, and because of that, patient is not getting sufficient blood supply to the myocardium during exertion. That is why pain is there only during exertion. Okay. And when I see this image, right, I know that it is going to progress from here to unstable angina, from unstable angina to NSTEMI, from NSTEMI to STEM. So can I say that a patient who has stable angina is at risk of developing acute coronary syndromes if I do not address in future? If the fibrous cap ruptures, the plaque ruptures, endothelial injury happens, then there will be sequences, right? There will be platelet plug formation, fibrin mesh formation, and patient may come with unstable angina, NSTEMI, or STEMI. So when it comes to management of chronic stable angina patients, first thing that we need to address is I have to reduce the risk of this patient progressing to develop acute coronary syndrome. That is one objective. Second objective, because of the narrow lumen, the patient is going to experience limitations in his physical capabilities. 100 मीटर नहीं चला जा सकता, 2 floors नहीं चढ़ा जा सकता क्योंकि chest pain होता है. So I have to take care of the symptoms. I have to reduce the development of symptoms. At the same time, also I have to reduce the risk of progressing to acute coronary syndromes, right? So can anybody tell me what can I do to reduce the risk of acute coronary syndromes? So for symptomatic management, what I can do, and for decreasing risk of MIs or acute coronary syndromes, what I can do. So I will address that. I will address Pacemaker angina also. To reduce the risk of developing MI. See, how is he going to develop MI? When atheromatous plaque expands further, the fibrous cap opens up, endothelium gets ruptured, and then there will be formation of platelet plug, right? Can I slow down the expansion of atheromatous plaque? Yes. How can I slow down? By reducing the deposition of bad cholesterol. How can I reduce the deposition of bad cholesterol? By reducing the blood cholesterol levels. How can I do that? By giving him statins, right? So statins can help me reduce the progression of expansion of the atheromatous plaque. Okay, if it happens, if atheromatous plaque ruptures, can I prevent formation of platelet plug? Yes, I can prevent formation of platelet plug by giving him antiplatelets like aspirin or clopidogrel, right? So that is how I can prevent this patient of unstable angina from progressing to become unstable angina, NSTEMI or STEMI. So for reducing the risk of acute coronary syndrome, we generally give them antiplatelets like aspirin or clopidogrel plus I will give him statins. That is the combination used for all patients with stable angina to prevent them from developing an MI. And on the other hand, for the symptomatic management, your blood vessel lumen is narrow. Because of that, blood supply to your myocardium is reduced. Rest का ठीक ठाक चल रहा है लेकिन exertion के time sufficient नहीं मिल रहा है. I can increase the lumen to increase the blood supply, right? So how can I increase the lumen? How can I increase the lumen of the blood vessel? Yes, so we have choices like nitrates. Can beta blockers cause the vasodilatation? Can beta blockers cause the vasodilatation? Yes, beta blockers can do. Can calcium channel blockers cause vasodilatation? Yes, they can do. So now I have a question. I have nitrates, calcium channel blockers, and beta blockers. On a daily basis, among these three drugs, which one will you advise for the patient? Calcium channel blockers, beta blockers, or nitrates? See, there are two things to achieve here. One, मुझे जो angina episodes हो रहे हैं patient को exertion के बाद, I have to reduce them and I have to increase his physical capabilities. 100 मीटर नहीं चल सकता है. अब I want to give him vasodilators so that he can walk 100 meters. He can climb 2 floors. And then when, despite being on some vasodilators, if angina appears, how will I manage? So to reduce angina episodes or improve exercise tolerance, we generally do not prefer nitrates as the first line agents. We generally prefer using beta blockers or calcium channel blockers beta blockers or calcium channel blockers. But when, despite being on beta blockers or calcium channel blockers, patient does some physical activity and angina start हो, अब उसको relieve भी करना, right? To reduce angina episodes from appearing, it is a different thing, and to relieve angina episodes. एक बार angina start हुआ है, so then how would I relieve? Yes, for relief, we would consider using nitrates as the drug of choice. And when we are using nitrates, we need to consider nitrates which can act quickly, right? So you need fast acting, as well as you would choose a mode of administration which gives you quick access to blood. So we would prefer using sublingual nitrates. So to summarize, a chronic stable angina patient is definitely at risk of developing an MI, and to prevent him from developing an MI, we need to give him antiplatelets and statins. And now to improve his effort tolerance or exercise tolerance, to reduce angina from appearing on a daily basis, we will put him on some vasodilators, and preferred vasodilators are beta blockers or calcium channel blockers. and despite being on beta blockers or calcium channel blockers, कभी कभार हो जाता है angina, so then he can take nitrates for a quick relief, and if he is taking nitrate, it should be sublingual nitrates. Okay. So the beta blockers are also vasodilators, right? See, remember, adrenaline is a vasoconstrictor. Sympathetic nervous system causes vasoconstriction. So if you block the sympathetic nervous system, you cause vasodilatation. Vasodilatation किया तो blood flow increase होगा, तो जो demand and supply mismatch exercise के बाद आ रहा था, वो आना कम हो जाए, and patient will be able to do more physical activities, more exercise, comparison to when he was not getting the drugs. Telegram group is called Dr. Patel's Medmania. Okay, so one more thing that we will address today before we sign off is there's something called as Prinzmetal's angina, which is also called as vasospastic angina. This is also known as vasospastic angina. So what is this? This is also a form of ischemic heart disease where there is no true occlusion of the blood vessel because of atheromatous plaque, platelet plug formation, or fibrin mesh. So in all other cases of ischemic heart disease that we spoke, we started with an atheromatous plaque causing the narrowing, giving rise to stable angina. Then plaque rupture, giving rise to a large platelet plug formation and maybe a little bit of fibrin, giving rise to unstable angina. Then myocardium dying in the subendocardial region, giving rise to end-stony. Then whole thickness myocardium dying, giving rise to STEMI. So in all these cases, the blood flow reduction is because there is an atheromatous plaque plus a clot. But if blood flow to the myocardium gets reduced without an atheromatous plaque, without a clot, mainly because your blood vessel is constricted, it is critically constricted, reducing the blood flow to the myocardium, you experience ischemic symptoms, but there is no atheromatous plaque or no clot, then we will call it as vasospastic angina or Prinzmetal's angina. Why is it called as vasospastic angina? Because here the angina is because of, here the angina is due to coronary vasospasm. Coronary vasospasm. So in such cases, if I give aspirin, if I give thrombolytic agents, will it help the patient reduce the angina? Can it help the patient come out of angina? No, right? Because here there is no role of platelet plug formation. There is no role of the fibrin mesh formation. Thrombolytics find no importance here. Antiplatelets find no importance here. So then how should I treat these patients? Obviously give a vasodilator, right? We should be giving the vasodilator. So just remember that there is no role of antiplatelets or thrombolysis in management of these patients, because here it is due to coronary vasospasm. So treatment will be with vasodilators. So for a regular case, you can consider using the calcium channel blockers, right? And whenever an attack of angina happens, as usual, sublingual nitrates will be the drug to go for. Okay. Most important point you need to remember about the Prinzmetal's angina is aspirin is contraindicated, because aspirin itself can precipitate vasoconstriction, and that can become a problem in patients with Prinzmetal's angina. In other cases, we're giving aspirin to prevent the platelet plug formation or progression of the platelet plug formation. But here, there is no role as such of a platelet plug in causing the angina, and by giving aspirin, I can cause more vasoconstriction, resulting in further worsening of the patient's symptoms. See, in stable angina, we are giving antiplatelets to prevent platelet plug formation. See, there is no platelet plug in a patient with stable angina, as you can see from the image. But आगे जाके, if the atheromatous plaque expands, then there is a possibility that the plaque may rupture. जब rupture होगा तो पहला step क्या होगा? Formation of a platelet plug. तो उसको prevent करने के लिए हम antiplatelets दे रहे हैं. That is why we are using the aspirin. Why are we giving statins? Statins हम इसलिए दे रहे हैं कि जो atheromatous plaque है वो expand ना हो, क्योंकि वो जितना expand होगा plaque rupture होने का chance उतना ही बढ़ता है, right? So this is the basic of ischemic heart disease that we need to know. I hope we have a basic conceptual idea कि हाँ stable angina क्या है, वहाँ पे pathology क्या है, एक्यूट कोरोनरी सिंड्रोम्स के अंदर क्या क्या आता है, वहां पे पैथोलॉजी क्या है. विद दिस वी विल कंक्लूड फॉर टुडे. इन द नेक्स्ट सेशन we will talk about the diagnosis and management of acute coronary syndromes. So we'll address how to recognize unstable angina, NSTEMI and STEMI. Hopefully this will be interesting for most of us because ECG is an exciting topic for all of us. We will learn how to recognize STEMI on the ECG. We will go through some MCQs and also some ECG images for us to get used to it. And then we will talk about the management of individual. Unstable angina कैसे manage करते हैं, NSTEMI कैसे manage करते हैं and STEMI कैसे manage करते हैं. So with that, I'm signing off, guys. I'll see you in the next class. Till then, have a good day.